Hello, everybody. Welcome back to the Incubator Podcast. We are live at Hot Topics in Neonatology, and we are joined by the legend, Dr. Reese Clark.
That's right.
You are on so many papers. That's why I said the legend. I mean, it feels like every paper that comes out, your name is somewhere on the author list. So you do so much work. Is this like, by the way, I wanted to ask you, do you do this full-time? Are you a full-time researcher, or do you still manage to squeeze in some clinical time?
No, I did through about 2018. So when I first started working for pediatrics, it was full-time. And then after 3 or 4 years, I missed it, went back to clinical in Greenville Memorial Hospital. And then got to a point where night call was pretty hard. And so then I've gone back and done pretty much research.
So night call did it for you.
Oh, yeah, no question.
Night call. Night call's doing it for me already, and I'm only a handful of years into practice.
That and a very small baby and forgetting my glasses in the call room.
Yeah, that'll do it.
I should have introduced you, obviously, by your title. You're a research consultant and a consulting associate professor for Duke University in Durham, North Carolina. Daphna, I'm going to let you take this first one.
Yeah, well, we've had some introduction to your session yesterday from the quality improvement palooza, using technology to drive your quality improvement initiatives. And your talk was specifically using the electronic medical record to advance quality of care in neonatal care medicine. That is a big talk.
It is.
It's a big title.
And it was interesting because I thought I had an hour, then I realized I had 20 minutes, so I was doing shrinking
the impossible.
So now we're going to shrink it
some more. And now we're going to ask you to do it even more, yeah.
Yeah, no, I think as I was thinking about this, short period of time, is the most important messages I'd like to leave us with is there's a ton of data coming in to electronic health records. And that leads to a responsibility. I would even call it a moral obligation to learn from that data.
Yeah.
And the first concept of meaningful use was that anytime you're collecting data, it should inform the care of the next patient. And so if we have this data, we need to learn from it. And, one of the first things we kind of worked on when I started working with big data and mainly the clinical data warehouse at pediatrics was, how do we identify patients with fungal sepsis? And it was a collaboration with Danny Benjamin. And first of all, you got to say, well, how are you going to define fungal sepsis? So when we think about data, there's structured data and there's unstructured data. The good thing about Baby Steps or Vermont Oxford Network is the data in those data sets is structured. In other words, data is entered by definition, and it's a pick list, which is very different than an electronic health record where you're trying to find necrotizing enterocolitis, for example, that's in a radiology report on pneumatosis. And
where you're asking the system to find it.
That's right. Okay. When you're using natural language processing or something like that. Well, and where is it? Is it in the radiology reports? Is it in the diagnoses? Is it in the procedures table where they did surgery? And so when we're looking at big data, knowing the source of the data, the type of data, and there's a nice paper on how do you look at and evaluate electronic healthcare data out of the CDC that just came out. Unfortunately, I can't give you the reference right off the top of my head, but that framework says, okay, before you start looking at the data, understand it very well. So you have a responsibility to understand your data and then begin to learn from it. And I think one of the biggest setbacks that I see if we look at all the data that's out there in over 100 different databases is there's plenty of data that's not being looked at consistently. So, for example, there's some stuff coming out of Epic for neonatology, but not nearly as much as you would see from, say, the Children's Network data or the FIS data or the Clinical Data Warehouse or Vaughan. And so capturing that data and learning from it is really important.
I think that's actually very exciting. So Ben will tell you, I'm not the most tech savvy. I struggle with our EMR, and we function on a number of EMRs in our practice. But it's exciting because I think the EMR has become such a topic of frustration for physicians and healthcare professionals. But if you look at it from this lens, it's actually super exciting. It makes you want to catalog all of the things so that we can learn from it.
Yeah, and I think there's fun in understanding how you can look at a whole data set and have it double check itself.
Yeah.
So, for example, if you're talking about surgical NEC, is there a documentation of a procedure that says that they had the procedure? It's not just a text or diagnosis. And if you're looking at intracranial hemorrhage and you have a neuroimaging data set, can you find it both in the diagnosis and can you find it in the neuroimaging table? And so the quality of the data can cross-check itself because there's duplicate information in there. And actually, I think that's part of the reason that we've had the success we've had is that there's overlap and where stuff is collected. And so when you look at across these data sets, even they're all a little bit different, the necrotizing enterocolitis incidence is about the same. The chronic lung disease, PDA is hugely variable.
You don't say.
No. And people ask me, well, can't you tell us from the data sets? No, there's too much variability in the practice. And actually, Viral Tolia and I just kind of wrote an editorial on a paper that came out, is that if we're going to think that we can learn how to manage the ductus from retrospective studies in neonatology, we're not going to be able to because there are too many. Did you use indomethacin early? Did you use ibuprofen? Did you use acetaminophen?
Yeah, what dose? How
Right.
long?
Yeah.
What dose, when? I think that's the key, and also variability, in my opinion, always is data in the sense that it tells you that there's work to be done there. Like you need to maybe put your nose in that data and see, like, hey, what are we missing as a field in terms of understanding this a little bit better? So there's always something to take away.
No, and I absolutely agree. Another really interesting observation we made that's historically important, and it would be interested to hear your comments on it, is we were preparing for a meeting with the FDA that was asking us about antibiotic utilization in the neonatal intensive care unit. And so one of the questions I just asked was, what are people using? So this was back in the early 2000s, and it was AMP, GENT, and cefotaxime.
Yeah.
And you had centers that were just using AMP and GENT, and centers that were only using AMP and Ceph. So, well, why is that? Well, the centers that were using Ceph were because they didn't have the ability to do gentamicin levels, which is something we did a lot back then, which we don't do anymore. And so I said, well, is there any difference? Well, we found that cefotaxime was associated with an increased risk of mortality, which subsequently was shown in other data sets. We weren't really sure exactly why. We tried to correct away. Was it because the kids were getting it because they had renal failure, or was it because they were more concerned about meningitis? We couldn't find a reason, but understanding that variability and then understanding that there was a difference, cefotaxime use came way down. Obviously, there were other things that changed, like fluconazole use going up, and fungal sepsis really went way down, which cephalosporins were associated with an increased risk of late fungal sepsis. So by understanding the variability in practice and then exploiting it, and then the second kind of different observation was done by Viral Tolia looking at vitamin A. And vitamin A just disappeared from the market. Well, now you can see, well, did it have any effect on chronic lung disease? And we didn't see it.
That's so interesting to look at it this way.
Yeah. I wonder, someone like you, who through your career, you've kind of been on the cutting edge of, using large data sets. But I wonder on an individual level in a NICU, I think there's still things we can get from our, local EMRs. What are kind of some of the lessons learned that we can take to our individual units?
Well, that's really another pivotal part of all this is quality improvement. And so I think that when you have data reports that can inform what your practice is seeing with regards to outcomes, with regards to use of human milk, it makes a difference. So people can now say, hey, well, look, we're falling out of bounds. Vermont Oxford has a great risk adjustment system to say, hey, look, you're doing this a lot more often than your colleagues. And then you can learn from it. You can make an adjustment, do the quality improvement effort, and then do a run chart and see if you've made things better. Dan Ellsbury, Robert Erspring, and others did our 100,000 Babies campaign work. And without the reporting system that we had internally and having our doctors come to meetings around quality improvement, which is Vaughn's model, it's not our model, but you can change multiple things and outcomes have improved. And both data from every data set that is looked at it over time, NRN, Vaughn, or us, you see big decreases in necrotizing enterocolitis, big decreases in ROP. Now, chronic lung disease hadn't changed, and that was, kind of something that was alluded to also during the quality improvement session is that it seems like we've plateaued. So what's the next big thing? And in my opinion, one of the big things we desperately need to do is be more consistent in how we all practice. Because now you can begin to do interventions across multiple practices to see what their impact is. But when we're all kind of doing it differently, the noise that's in the system prevents you from understanding the signal.
That's super interesting.
Yeah.
There's so many books written about exactly with that title, the noise and the signal, or whether it is Daniel Kahneman's Noise recently that just came out. Like it's so interesting to look at that and apply it to our field. There's so much work to be done. Reese, thank you so much for dropping by. Congratulations on this work, and we'll see you around the conference hall.
All right. Well, thank you.
Thank you.
Thank you.